Good afternoon, ladies and gentlemen. Chairman, I would like to thank Patrick first for inviting me to participate in this conference. And within the next 10 minutes, I will summarize for you the current management of hepatorenal syndrome. Have no disclosures. I will begin with a case showing the problem, and then I will show you the current definition of hepatorenal syndrome, which is actually one of the phenotypes of acute kidney injury. So I will define AKI as well. And then the current management of this complication, the standard of care. And also I will include a couple of words about the difficult challenge of differentiating functional versus organic kidney disease and the potential help of biomarkers. And finally, the possibility of giving priority to those patients on the waiting list, considering that MELD score declines after successful therapy. So this is a 61-year-old man with decompensated cirrhosis, ascites, encephalopathy, large varices, who is admitted for drowsiness and increased abdominal circumference. The lab shows evidence of SBP with a creatinine that raised from 1.1 to 1.7, indicating an important degradation of kidney function. MELD score at that time was 28. So in this patient with the decompensated cirrhosis, it is clear that the definite therapy is liver transplantation. But what brings us today is, does this patient accomplish criteria for acute kidney injury, and if so, of hepatorenal syndrome as well? So here we enter into the second issue, which is the definition of acute kidney injury in patients with cirrhosis today. We all know that conventional criteria were not appropriate to early diagnose these patients since the values for creatinine were too high. So the International Club of Ascites, led by Paolo Angeli in 2015, took the KDIGO criteria to define acute kidney injury in cirrhosis, and therefore an increasing creatinine of only 0.3 milligrams per deciliter in the last 48 hours or more, or an increasing creatinine of 50% from baseline was enough to define acute kidney injury in these patients. This new definition is clinically relevant and closely related with management because we can early identify patients with kidney injury, and the universe of these patients doubles the one included in the old definition. And we can so move forward with therapy. The diagnosis of these patients with these criteria is also relevant because AKI in cirrhosis means a marked increase in mortality. And therefore, early therapy is needed to rescue these patients, as we will see later. Hepatorenal syndrome is one of the phenotypes of AKI, and although the pathogenesis is essentially functional, it is associated with the more severe stages of acute kidney injury. And therefore, it's associated with a very high mortality rate in the absence of effective therapy. Since 2015, there are new criteria to define HRS proposed by International Club of Ascites and adopted by EASL and other societies. HRS, so is part of AKI, is HRS-AKI, that replaces previous type 1 HRS. No response to today expansion with an established dose of albumin is required. Absence of shock also, nephrotoxic drugs or organic kidney disease. But please note that patients who fulfill this criteria may still have structural damage. So coming back to our case, the question is if our patient had AKI, and the answer is yes, because as you can see, he increased creatinine more than 50% from the value before admission. So therapy for SBP was started with antibiotics and albumin. 2 days later, under albumin, renal function declined even more, creatinine reaching 2.1. So now the question is, did our patient have HRS? And we can clearly see the outcome here. He had AKI since the admission, no evidence of organic kidney disease, and no response to 2 days of recommended expansion with albumin. Creatinine increased even more to 2.1. There was absence of organic kidney disease. So yes, the patient had hepatorenal syndrome by the current definition. So the answer to this question is yes, and the patient was put on Terlipressin, which was added to albumin at day 3. So let's see the current management of this complication, which is the standard of care. Early initiation of therapy with Terlipressin and albumin is crucial and may increase the likelihood of hepatorenal syndrome resolution, improving short-term survival. Terlipressin can be administered by IV boluses or by continuous infusion, and albumin must be associated at these recommended doses. Noradrenaline can be an alternative when Terlipressin is not available, but recent trials suggested that maybe the efficacy is more limited. Now, even when HRS continues to be an essentially functional disease, it can anticipate acute tubular necrosis or even coexist with ATM. And this may explain why at least part of the patients do not respond to recommended therapy or do not recover after liver transplantation. And the problem here is that the differential diagnosis between HRS and ATN is not easy and the treatment differs. So do we have any tool to help here? Recently, several biomarkers have been studied, but no clear cutoff value separates hepatorenal syndrome from ATN. And moreover, biomarkers predictive of recovery from HRS after liver transplantation are unfortunately lacking. But take a look at what happened now in our patient. He was put under Terlipressin treatment, and creatinine at day 7 was 1.3, so the patient responded. But look what happened with the MEL score. It decreased from 28 to 24. So the chances of rapid liver transplantations are much lower now. The penalization of HRS patients that respond to therapy was recently demonstrated in a couple of publications, as in this from Salvatore Piano, where they showed that responders weighted more than twice than non-responders because of a decrease in MEL score at the time of liver transplantation as a result of therapy. So as a result of this prolongation on the waiting list time, a similar proportion of patients died while waiting, even after responded to therapy. And therefore, experts in the field suggested using baseline MEL score pretreatment values for maintaining priority on the waiting list to responders to Terlipressin and albumin. And this strategy seems reasonable, and some countries have already implemented it in their policies. On summary, HRS-AKI in the patient with cirrhosis is a severe complication associated with decreased survival. The current definition of HRS-AKI allows an early diagnosis and therefore an early onset of therapy. Phenotypic diagnosis is essential for proper therapy, but often difficult to establish. Biomarkers hopefully may help in the future. Terlipressin and albumin is currently the best therapy available to achieve improvement or even reversal of hepatorenal syndrome. Liver transplantation is the only curative strategy, and therefore policies should be adopted in order to transplant these patients as soon as possible. With this, I finish my presentation, and I want to thank the audience and my colleagues in my unit in Buenos Aires. Thank you.